posterior chamber of the eye, behind the lens, isn't it? That's where the vitreous is, behind the lens. Okay? If there is infection there, it will obviously affect the ciliary body. And if it affects the ciliary body, it will ultimately affect the pupils, which are anchored on the ciliary body. So they will not be normal, in severe cases especially. So you have rapid onset of severe pupillary reactions abnormal. There. RAPD is present. What is RAPD? This is called relative afferent pupillary defect is present. What is RAPD? I will leave it to the end. When you do a CT scan, it shows opacification of tissues posterior to the orbital septum. Okay, like this, I think this is this. Before we go the rest, this is the right orbital cellulitis. You can see all the swelling there. This one is completely normal. This one you have to elevate the upper lid to see the eyeball. And when you do a CT scan, where there is no infection within the orbit, here, it looks black, it's empty, no infection. But where there is infection, look, it looks whitish. The pus is in here, orbital septum, and pushing the eyeball forward. So this eye, which is affected, tends to be pushed outward, what you call proptosis, because of the infection, more buildup of the pus here. Obviously, ocular motility will be disturbed because the muscles are here, they are also inflamed. Pupillary reactions will be abnormal. The optic nerve is here, it's compressed as well. You see the point? Optic nerve is here. Muscles which move the eyeball are inside this orbit. So any infection, a severe infection, will lead to compression of those structures. And therefore, ocular motility in this particular eye will be affected. The movement will not be normal. Pupillary reaction will be affected because of compression of the optic nerve. This side, there's no compression. Where there's no compression, it looks completely dark because there's nothing there. These are the socket bone. This is the nose. Okay, sinuses in the nose. RAPD, relative afferent pupillary defect. I said it will be the last one. You want me to give you the answer? I'm not giving an answer. You have to find the answer and you tell me. Where?
Yes.
Huh? I know.
We're here.
We are here. That's a picture. So we go this one now. These are the complications which you have, ocular complications, exposure keratopathy. Exposure keratopathy, you can see that there's buildup of pus in the posterior part of the eyeball. So there's pushing of the eyeball forward. Especially in long-standing cases, there will be proptosis where the eyeball is pushed outward in the affected eye. And in these particular cases, everyone knows which eye the patient is complaining about. Because the other eye maybe will still be normal, no pain. But this one is even protruding out, it's all inflamed around. You can't miss the diagnosis. So with the protrusion of the eyeball, long-standing cases not being handled properly, you have exposure keratopathy. The cornea is being exposed. The lids can't close in front of the protruded eyeball. So you have exposure keratopathy. The cornea gets affected also. There is raised intraocular pressure. There is occlusion of the central retinal artery or vein. Endophthalmitis occurs. Endophthalmitis, the infection initially is outside the eyeball, and it may end up inside the eyeball. When it goes inside the eyeball, the vitreous inside affected, that's what you call endophthalmitis. When it's outside the eyeball, within the orbit, that is inflammation of the orbit. Intracranial spread. Why should it spread intracranial? It can spread perineural. The optic nerve goes straight into the orbit, isn't it? You get sensation from here. The optic nerves, they go inside. Yesterday we were saying first there is a chiasma, then you've got optic tracts which end up in the brain. So you can have spread of the infection right up to the intracranial space, meningitis, brain abscesses, or cavernous sinus thrombosis. All these can occur. Subperiosteal abscess. Every bone is covered by periosteum. It can be there. And this is usually located along the medial orbital wall. Treatment. This is what I want you to understand better. You are the eyes and they say eyes and what? And you'll be the ones representing us there. At least if you can see that there is a need for this patient to be properly treated, don't start keeping them or giving them eye drops. This is infection in the whole orbit. They need proper hospital admission, antibiotic therapy, IV, ceftriaxone, or 2 milligrams IV QID. You put in the injection. That's how it's not constant, this one. You can put it in the injection. You put up a cannula, so much, 2 grams you put there 4 times a day. And you are recording on the chart. IV metronidazole, 500 milligrams, 6 hourly, maximum dose, 4 grams per day. Metronidazole does what? It's what? An antibiotic? This is antifungal. Okay? This is antifungal, this is an antibiotic. A combination is always nice. Continue antibiotics until patient is apyrexic when the temperature is settled for 4 days. Continue monitoring the optic nerve function 4 hourly. By monitoring the optic nerve function, obviously, it's pupillary reactions, visual acuity, how much can you see, color vision, and light brightness appreciation. These are the tests you can use to check that the eye is still functioning despite all the swelling we have. So you keep monitoring this while the patient is on treatment. There is no need to put, you are not checking this. In the end, after 1 week of treatment, that now is blind. It means you missed the boat, sailed away into blindness. Questions, ladies and gentlemen. I want you to be aware of this. You will be our eyes and the representatives where you will be. You recognize the condition. This is how it should be handled. There's nothing like mukabwere 2 weeks time and to the business and 2 weeks. Look, this is a case. Once you think it's a orbital cellulitis, patient should be admitted. Instead of giving floor beds to chaps who are drunk, it's better you give one who needs the actual treatment properly. Okay. Treatment continues, investigations You do white blood cell count. It means you draw the blood and you send for full blood count. You also send for blood culture and sensitivity. If it is possible, a CT scan of the orbit and sinuses and brain. This will show if there are abscesses which have formed. A lumbar puncture, if cerebral signs develop, like meningitis, that's the meaning of cerebral signs. Signs suggestive of meningitis. If they are there, a lumbar puncture must be done. Surgical intervention to drain the orbital abscess, you need surgeons. If you are in a rural area, you might have a good surgeon who does this. If he is not there, it's time to evacuate this patient to somewhere where they can do this. Orbital abscess will show in that CT scan. Question, yes.
On the ocular complication,
Yes.
can orbital cellulitis cause glaucoma?
No. Why should it cause glaucoma? What is glaucoma? When we're talking of glaucoma, we're talking of production of aqueous and excretion of aqueous.
Maybe this question maybe can be coming from, where is that? Here.
Just what question is here again? Bring the question which is here.
Okay.
That's the question.
Since there is raised intraocular pressure, said on the ocular complication, can orbital cellulitis cause glaucoma? Since there is raised IOP. Where was that slide?
You look for it, let's see. What is the slide you are banking
Here.
on?
On the complications.
Ocular exposure keratopathy, raised intraocular pressure.
So the question is coming from here.
Okay, can it cause raised intraocular pressure?
Can there be glaucoma?
No. It says raised intraocular pressure. Glaucoma is when glaucomatous changes have occurred. You understand? If there's just raised pressure, it's raised pressure. Glaucoma has raised pressure. But apart from that, when you say glaucoma, you will find the signs of glaucomatous damage on the eye. This is something which can occur in 24 hours. Pressure may be raised, but when you check on the optic disc, there will be no capping. There will be no glaucomatous capping. To have that is long term. So we should be very careful what glaucoma
Is
and raised pressure only. Yes, glaucoma ultimately starts with raised pressure.
it's an association.
Yes. Any other question, ladies and gentlemen? Amana pata valembere pati glaucoma, valembere fiat raised pressure. So these are the investigations. Especially when there is infection, a full blood count will be better. Blood culture and sensitivity. Oh, there's a question. Sorry.
So I don't know if there are any other questions.
Any other questions, ladies and gentlemen?
So we go to this one.
Differential diagnosis of what? What is this? Huh? Oh, idiopathic orbital inflammations. IOI. These abbreviations.
Let me just cancel this.
Eh?
Let me cancel this one.
We cancel this one.
This one. Okay.
I cancel.
No.
I leave it now.
Yes.
Okay. Idiopathic
Okay.
orbital inflammatory disease, orbital pseudotumor.
There's a question. Okay, it's a concern.
But
thanks, it's clear now.
What was clear?
The explanation over the intraocular pressure.
Okay.
Concerning.
Okay, it's clear now. Okay, thank you very much. It's clear. No, the fact that there is raised pressure, to label it as glaucomatous, as glaucoma, there must be glaucomatous changes. Raised pressure, yes. Because sometimes you are going to check, to have patients who, when you are seeing them, the pressures are not that high. But when you do a fundoscopy, you find the optic disc is capped. What is it? Glaucoma. If there is an optic disc capping and there is raised intraocular pressure. If it's only raised pressure, you see, ocular hypertension. The disc is not capped. There are no suggestions that there is glaucoma there. It means, you see, ocular hypertension. Any infection, any condition around the eye, especially any inflammation, there will be, inflammation there. There will be, in the initial stage, there will be ocular hypertension. The capping is a long-term thing. This inflammation is a short-term thing. Today you can be okay, 2-3 days, you are presenting with this. But glaucoma doesn't come that way.
It's gradual.
It's a gradual thing. The patient even doesn't even know about it. He'll be coming and enjoying himself. He doesn't know because there is no pain associated. And the central vision is the last to go in terms of visual field defects. The center bit is the last to go. You come only to check that this is the last bit of vision he has got. When you draw your visual fields, you find all around is all blind. Sight is just a small island of vision. So we proceed now to the next.
We can look at idiopathic
orbital inflammatory disease. People are happy with the first one, eh? Okay, they are happy. I'm also happy. So let's go now to idiopathic orbital inflammatory disease. Idiopathic, what is the meaning? You don't know exactly the cause here. You know, it's not something you are going to treat with antibiotics. This is idiopathic. The cause is unknown. But there is orbital inflammation, you know. Yes. Idiopathic orbital inflammatory disease, uncommon disease characterized by being non-neoplastic. It's not a tumor. Non-infective. There is no infection here. But it is a space occupying orbital lesion. There is inflammation where there is, that inflammation is not due to any tumor. It's not due to any infection at all. But there is inflammation. That's why they are talking of idiopathic, unknown cause. The pathology is unknown, clearly. Orbital inflammatory disease. It's non-infective, non-neoplastic, but it's a space-occupying orbital lesion because it's within the orbit. Inflammatory process may involve any or all the orbital tissues. What are the orbital tissues we're talking about? Muscles, all the soft ones which are there, you know. The whole lot can be involved. This is usually unilateral in adult patients, but maybe bilateral in children. Histology shows inflammatory cellular infiltration with reactive, which is fibrosis. What it means is this. It can occur in adults or in children, this inflammatory process. But the inflammatory process is non-infective. It's not due to tumor. But you find there is that inflammation in there. Okay. Which is with a lot of fibrosis within the orbit. And this leads usually to protrusion of the eyeball. The orbit is behind the eyeball. If there's something now coming up there and occupying the space, the eyeball tends to be pushed forward. Presentation, you have acute periorbital redness, swelling and pain. Clinical signs, congestive proptosis. Because of this inflammation behind the eyeball, there is a tendency to push the eyeball forward. And that's what we call proptosis, pushing of the eyeball forward. When you look at the two eyes, one eye looks protruded, this other one looks okay. If it's protruded, the eyelids, the upper and the lower, can't completely cover it. Normally, you and me, we are able to close the eyes anytime we want to close. Him or this lady patient here who only close one eye, which is not yet affected, while the affected eye, very difficult to close because there is this inflammatory condition coming out, building up behind the eyeball and pushing the eyeball forward. This is what is called congestive proptosis. Ophthalmoplegia may occur. What is ophthalmoplegia? Anyone with an answer, please? Optic nerve dysfunction is going to occur because of compression. Inflammation behind the eyeball will always give you optic nerve compression. But ophthalmoplegia, apart from compressing the optic nerve, the muscles are also compressed. And therefore, movement of the eyeball is affected. They can't easily move that eye. Look to the right. If the right eye is the one with this, they can't move the eyeball because the inflammatory, the cells, the muscles in this particular orbit, they are inflamed. That is ophthalmoplegia. Unable now to move that eyeball. And naturally, all these are unable to move because of the inflammation. Equally, there is the optic nerve dysfunction, compression of the eyeball. Investigations, the best investigation is a CT scan, which shows, CT scan will go across, it will show the eyeball, it will show all the tissues which are there, the CT scan. Will show ill-defined orbital opacification behind the orbital septum. Orbital septum is in the front. It means all from here going backward, except leaving the eyeball in the center, there is all opacification. Course of disease follows one of the following patterns: either spontaneous remission after a few weeks without sequelae. Sequelae is without side effects. Just store and the whole thing. If you are Mwinganga, it means I've got money. If I just did it, people will be very grateful. No, there can be spontaneous remission in such cases. But this is a jackpot for the witch doctor. But don't wait for the witch doctor to help you to give you a jackpot. Intermittent episodes of activity with eventual remission may occur, or severe prolonged inflammation eventually leading to progressive fibrosis of the tissues resulting in a frozen orbit. Frozen orbit means all the tissues, slowly, this fibrosis holds now the eyeball. It can't move. That's the meaning of frozen tissues. The muscles can't contract. And you have this frozen orbit of thermoplegia, unable to move, associated ptosis, visual impairment due to optic nerve involvement, compression. The optic nerve involvement we're talking here is compression. Treatment outline. One observation for relatively mild disease in anticipation of spontaneous remission. This statement means you will be able to monitor the patient. It's not to tell the patient that because this patient is under observation. And if he's under observation or she's under observation, you must give them time so that you see what is happening. And you tell them, if you find the pain, but explain the condition to the patient. Give them NSAIDs, this is non-steroidal anti-inflammatory drugs to help the pain. NSAIDs, non-steroidal anti-inflammatory drugs. These are effective and may precede steroid use. Systemic steroids may be used only when diagnosis has been confirmed. Before diagnosis is confirmed, non-steroidal anti-inflammatory drugs are recommended. Then the systemic steroids to be used only when diagnosis has been confirmed, and that is oral prednisolone 60 to 80 milligrams per day. Slowly you reduce with as the patient improves. If the patient started at 80 and you are looking at the patient has improved, you also keep on reducing as people are coming for review, as long as there is a clinical response. Biopsy required in persistent cases to confirm the diagnosis and rule out tumor, cancer. If you are giving this treatment and the patient is not improving, it's better, in other words, you consider a biopsy to be done to confirm the diagnosis which you have or to rule it out. Not when the need a diagnosis, but not improving. So if the patient is not improving, consider possibility of a biopsy. In your situation, you may not be able to do a biopsy, but send to a station where they can do a biopsy. We've done this, so we are referring, maybe you could consider a biopsy. These notes will be with you. These will be your reference notes when the patients are there, how to go about it. So no excuses. Indications for biopsy: steroid therapy failure, bilateral cases in adults, and a case with the atypical presentation, not clear-cut presentation. You're not very sure of what it is. It's better you consider biopsy. Okay. You are giving steroid therapy, not working very nicely. Bilateral cases, well, this is usually unilateral. Bilateral cases, it's a bit not the usual pattern. Atypical presentation, all these should alert you to consider biopsy. If you can't do the biopsy, you can send to a hospital where they can do a biopsy. You can explain, this is what has happened. I'm referring, sir. Maybe you could consider doing a biopsy or for your further evaluation of the case. Radiotherapy considered if there is no improvement after 2 weeks of adequate steroid therapy. Low dose 10 gray may produce remission. Those doses of radiotherapy, they are in grays, isn't it? Antimetabolites may be used, methotrexate, mycophenolate may be necessary. Systemic, what's this? Inflixin. This is a inflixin. This is an anti-cancer drug. Huh? Okay. I think so. Is a tumor necrosis factor inhibitor. May be effective in recurrent or difficult cases that have failed to respond to conventional therapy. Any questions, ladies? Or we proceed to the next one. Thank you. Differential diagnosis of IOID. Idiopathic orbital inflammatory disease. Bacterial orbital cellulitis. Severe acute thyroid eye disease. And systemic disorders, cholestasis nodosa, Waldenstrom's macroglobulin, malignant orbital tumor, ruptured dermoid cyst. These are the possibilities. Sometimes investigations need to be done. Not even sometimes, all the times, to rule out some of these things. Where you have a chance to a biopsy to be done, you might get away and they have an answer. Take a second.
Question time.
Oh, okay. I'm wondering where. Question time, he says. Yeah.
I have a pusher.
Oh, now we push
Yeah, just.
Okay. Let's hear what they want to hear.
Questions?
Questions. My questions, we go and do other things. We proceed.
We have one more slide, 1 for 48.
Oh, no, we are still around. No, we're not going anywhere. We're not going anywhere.
What's fungal infection?
Candidiasis usually is the commonest. Candida albicans. You heard of Candida albicans?
So when it affects the orbit, yes, what do you call it? Since the other one was bacterial.
This is fungal. Orbital. This is fungal.
Orbital is fungal. The ones we saw.
First, let me hear your the question. What did I say? When it affects the orbit,
what do
bacteria,
they call it?
You call it what?
Orbital.
No.
That is when it's
in the orbit.
Most common, we saw the.
But it's not.
Most of the.
What I'm trying to say, when you say orbital, orbital does not tell you the cause unless you say orbital cellulitis due to fungus. Understand?
Yeah, maybe I can ask that question. What orbital infection?
Yeah.
Which is due to fungal?
It is normally spread from outside inside. Normally. For example, you can have an injury with an infected, with a material which is infected, then you end up having orbital cellulitis there, fungal orbital cellulitis. Because from outside, for the infection to go behind the orbit, usually it's associated with some sort of trauma of some kind, injury of some kind.
There's a question here.
Yeah.
So what is the difference between IOID, which is idiopathic orbital inflammatory disease, and bacterial orbital cellulitis?
Bacterial orbital cellulitis, you know the cause, that is bacteria. The other one is idiopathic and known cause. It's idiopathic orbital inflammatory disease. There is no cause you can say this is the bacteria causing this, but you find that there is inflammation of the orbit. When you try to do the samples, it's not giving you any bacteria. It's not giving you anything. That's the one they label as the IOID, idiopathic orbital inflammatory disease. Idiopathic without a known cause, so to say. So that diagnosis is not something you start off from the day one to make it, to say it's IOID. Because you first have to do biopsies to try and confirm what is the cause. Only when you fail to get anything, that's when you can say it's idiopathic and known cause. That diagnosis must be the one coming last after you've done the investigations. Not the first day you say, oh, this is IOID. No. What you're saying, IOID, may just be simple bacteria, orbital inflammatory disease.
Okay. Then I think I can comment on that one. I think one of them has a lesion, due to a lesion in the orbit, the IOID.
The lesion.
There's a lesion.
Yes, but the cause.
It's unknown, yes.
That's the point. This is the cause. The lesion is there. The cause is unknown. Unknown pathology, idiopathic.
Then with
bacteria is straightforward. Bacteria won't, very unlikely that it will be there. It will normally form an abscess of some kind.
And what other difference? There's another difference with the nodes. Does IOD require massive treatment as the other one?
No, what it requires is IOD will be the last diagnosis. It will be at the end. Your diagnosis, that diagnosis of IOD has to come at the end.